Hello everyone, welcome to my YouTube channel. First of all, thank you for all the immense love that you guys are giving me. Today in this video, we'll be talking about odontogenic keratocyst. So if we split the term first, then odontogenic means something which is formed from tooth-forming tissue or its remnants. And keratocyst, see, it is a cystic lesion and it is known as kerato because the lumen of this cyst is almost filled by the keratin. The lining epithelium secretes keratin and this is completely filled in the lumen. This term was first coined by Philipson in 1956. Whereas the features of odontogenic keratocyst was identified by Pinbock and Hansen in 1963. Now, if we talk about, see, whenever we are writing any answer of oral pathology, it has to be under certain points, which would include, most commonly, but not always, introduction, then etiology or etiopathogenesis, after that clinical features, radiographic features, histological findings, lab findings, then diagnosis, differential diagnosis, and treatment. So here, odontogenic keratocyst, it has 6 special features, okay, which we need to mention in the introduction. First of all, it is a reminiscent of the odontogenic epithelium. It has highest recurrence rate, which is about 60%. It has high epithelial turnover rate. This is because of the increased number of mitotic figure in the epithelium. Along with that, it shows positivity to certain proliferation markers such as P53, PCNA, Ki67. Now, this cyst is known to have an aggressive behavior. Why? The reason for the aggressive behavior is the proliferation and budding of the basal cells of the epithelium. So the basal cells, they proliferate and give out different satellites, cysts. Therefore, they bud. And this is the reason why this cyst is known to have an aggressive behavior. Along with that, the basal cells show palisading. This is a characteristic feature of odontogenic keratocyst. And the epithelium connective tissue interface is flattened here. Next. So, you must have heard that OKC or odontogenic keratocyst, it has been referred to as KCOT, which is keratocystic odontogenic tumor, numerous times. This is based on the clinical behavior of the odontogenic cyst. Okay, it was first time in 1967 when Toller gave his view that OKC should not be treated as a cyst, rather it should be considered as a benign neoplasm. After which, in 2005, WHO classified OKC as keratocystic odontogenic tumor. Now, the reasons which WHO gave for this classification of OKC as keratocystic odontogenic tumor was because of its aggressive behavior, because of its high recurrence rate, and because of the PTCH gene mutation which was seen in OKC. This is not considered now because, see, OKC, first of all, there is no proper genetic and molecular evidence to consider OKC as a tumor. Second, PTCH mutation, it is seen only in syndromic cases. Along with that, it is also associated with dentigerous cyst and orthokeratinized OKCs. So it was in 2017 when OKC was considered or reclassified as a cyst and not as KCOT or not as a tumor. Along with that, certain other points if we look at while saying this is, see, first of all, any tumor, it is a swelling or a neoplasm. And this word tumor, this cannot be used for a lesion with cystic morphology. Along with that, OKC, it does not show any growth autonomy. And numerous times it resolves spontaneously or with decompression. So this cannot be considered as a tumor. Next, if we talk about the etiology of OKC, it is derived from dental lamina or rest of dental lamina, which is the cell rest of Serrae. Moving over to clinical features of OKC. Let us first talk about certain predilections. See, this can occur at any age, but it is more common in 10 years, between 10 years and third decade of life. It has a male predominance. Along with that, mandible is more commonly involved as compared to maxilla. And mandible it is more commonly seen in ramus or third molar area, followed by first molar, second molar, and anterior region at the last. And in maxilla, it is more common in the third molar area, followed by in the cuspid region. These are the percentages of the site predilection of OKC. A small OKC is usually asymptomatic. Large can represent with pain, swelling, and drainage. And it can also happen sometimes that if the OKC is extremely large, it has no symptoms. One characteristic feature of OKC is it grows in anteroposterior direction. So, since the cyst grows in anteroposterior direction and within the medullary cavity, it has no bony expansion, usually. This is how it can be differentiated with dentigerous cyst and radicular cyst, because the same size of dentigerous and radicular cyst would be showing bony expansion when we compare it with OKC of the same size. Multiple OKCs are seen in syndromic cases, which is nevoid basal cell carcinoma syndrome or the Gollin syndrome. We'll be talking about this in the coming videos. Now, if we talk about the radiographic features of OKC. So, it is well-defined it appears as well-defined radiolucent lesion with smooth corticated borders. Okay. Now, if large lesions are present, especially in the ramus, it can be multilocular because of the presence of bony septae. It is associated with unerupted tooth in 20 to 40% of the cases. There is less chances of root resorption in OKC when compared to dentigerous and radicular cyst. There are 4 different radiographic variants of OKC. The first one is the extraneous type. Extraneous type means it is seen somewhere else, for example, in the body or the ascending ramus where the tooth is not present. Second is the envelopmental type. It envelopes the tooth around which it is formed or to which it is associated. Third is the collateral type, which appears adjacent to the root of a tooth. Whereas the fourth one is the replacement type. In the replacement type, there is no tooth, means the tooth is absent and only OKC is seen. Next, if we talk about lab findings, then a clear or cheesy fluid is seen arising from the OKC. This is due to the large amount of keratin present. Moving over to the histological features which are seen in OKC. Okay, so first of all, we'll move from inside to outside. I have like drawn a rough diagram of the histological features which are seen in OKC. What you can do is, you can, in exam, whenever we are in a hurry, so it is not possible to draw the complete diagram. If we draw a square, we can divide it into 4 quadrants, and in any one of the quadrant either, we can draw the diagram, or in half of the quadrant, we can draw the diagram. Okay. So, first of all, in the inside of it, it has certain parakeratin squamps. After that, it has a cystic lumen. The cystic lumen consists of clear cheesy material from the superficial layer. Then it has corrugated parakeratinized surface, which is present in more than 90% of the cases. Okay. After that, it has uniformly thickened 6 to 10 cell layer thick epithelium. This is also a characteristic feature, that it has uniformly thickened 6 to 10 layer thin epithelium. Okay. Then it has a thin connective tissue capsule, which is made up of mature collagen and fibroblast. It has the outermost layer of the cyst. It has surface corrugations without rete ridges. So the proper rete ridges, these are not present in OKC. The basal cells, they show prominent palisading, and the nuclei of these basal cells, they are hyperchromatic. Because of this palisaded appearance, it is also known as the OKC is showing the picket fence or the tombstone appearance. Now, more than 90%, as shown here, more than 90% of the epithelium strip off the connective tissue, means there is a separation between the cystic lining from the capsule. Along with that, numerous daughter satellites bud from the original cyst, and these are daughter cysts bud from the original cyst. These are known as either daughter or satellite cysts. It also contains certain cholesterol clefts and hyaline bodies. So, these are the histological features which are seen in OKC. A point to remember is that OKC can be differentiated from other cyst like dentigerous or radicular or any other cyst only with the help of histopathological examination. That would be the diagnostic criteria for OKC. Now, OKC, as I have told you earlier in the introduction, it has high recurrence rate, which is about 60%. So what are the reasons for high recurrence rate of OKC? First, there is increased cell proliferation activity in the epithelium of OKC. Along with that, there is budding of basal cell epithelial layer. So the basal cells of the epithelial layer, there is budding of those cells, because of which it gives rise to remnants or daughter cyst. Along with that, there is parakeratinization of the epithelial layer. There is subepithelial split in the epithelial lining, which I have shown here. And it has a thin connective tissue wall. There are presence of remnants or rests or the daughter or satellite cyst, which also leads to the high recurrence of OKC. Next, moving over to the last part, which is the treatment of OKC. So, it depends on the size of OKC. If it is small, then enucleation is preferred. With enucleation, we mean that there has to be, if this is the cyst, a small cyst in the jaw, we will remove the entire cystic wall, wash out the cystic cavity with Carnot solution. Now, what is Carnot solution? It is a combination of 100% ethanol, chloroform, and glacial acetic acid in a ratio of 6:3:1. This helps in tissue fixation, removal of remnants, and it is also a method of chemical cauterization. Next, if the cyst is large, then marsupialization needs to be done. With marsupialization, we mean that a small window is created. So if this is the bone and it has a large cyst, then a small window is created connecting a drainage tube to this area. When the cyst shrinks, then enucleation is performed and the entire cystic wall is removed. Along with this, we need to evaluate the patient for the syndromes for the associated syndromes in which OKC is seen. This also we'll be discussing in the coming videos. Thank you.